So we are starting in three,
Yes,
two,
we can start.
one. Please start, sir.
So, a very good evening, everyone. I am Dr. Himanshu from the biomedical team. So, firstly, I'd like to welcome you all, the speakers, the panelists, and the participants, to take out the time from your busy schedules and attend this BEAR organized eyesight meeting. So, today in the agenda, we have two talks. The first talk will be by Dr. Abhishek Sachdeva, who's a consultant ophthalmologist from Sachdev Netralaya, Jammu. And Dr. Sachdeva will be speaking on the different molecular characteristics of the different anti-VEGFs which are available in the market right now. So we all know that there are different anti-VEGFs which are available in the market. And so it becomes a little bit confusing. So Dr. Sachdeva will be throwing some light on the molecular characteristics of different molecules which are available. Now, the second talk will be given by Dr. Bajwa. So, Dr. Bajwa is based out of Punjab and he'll be speaking on the disease and AMD. What are the critical information which is needed? Hello, am I audible?
Yes, sir, you are audible.
Okay. So the second talk will be by Dr. Suraj Bajwa, who will be speaking on NAMD and what are the critical informations which need to be known by the clinicians to enhance the patient outcomes. To moderate and to drive the discussion, we have three panelists with us, Dr. Sanjay Sachdeva, Dr. Pranav Gupta, and Dr. Shilpi Kapoor. So with that, I would like to hand over the session to our first speaker, Dr. Abhishek Sachdeva. Sir, over to you. Dr. Abhishek, can you hear me? Hello. Dr. Abhishek.
Dr. Abhishek, can you hear us?
Sir, if you are speaking, you are on mute.
Dr. Abhishek, can you hear us?
I can hear. Hello.
Yes, sir, we can hear you.
Yes. So, good evening, everyone. I must thank all the organizers and all the panelists and speakers who are present here and all the guests who are here. So, to start, I'll speak on the topic evaluating anti-VEGF drug molecular characteristics and their impact on treatment success.
So I would request the other participants to please mute the mic apart from the speaker.
So, as an additional disclaimer, I must tell that some of the data, values, and comments that have been included in the slide deck have been sourced from the FDA review document, and below is the guidelines of how it has been procured. So, as of all the pathophysiology of activation of VEGFR1 and VEGFR2 by diabetes leads to impaired vascular defect, impaired retinal blood flow, which leads to hypoxia in the body, which promotes the formation of VEGF and PGF, which both leads to neovascularization and inflammatory cytokines, and both of them lead to the vessel leakage and edema is developed with this. So with the newly aflibercept So the mechanism of action of aflibercept is that it targets the VEGF, the master regulator of disease pathology, and additionally targets the key ligand PIGF. So the VGFR1 domain 2 binds with VGFA and VGFB in PIGF, and the VGFR2 domain 3 binds with VGFA. So when the VGFR1 binds with the VGFA, B and PIGF, this leads to decreased inflammation, decreased neovascularization, and decreased retinal vascular leakage and edema. And the VGFR2 domain, when binds with VGFA, it leads to decreased inflammation, decreased neovascularization, decreased retinal vascular leakage, and edema. Globin G1, and which leads to. So the major advantage of this the drug is that it binds to the multiple targets like the VGF-A, VGF-B, PIGF, and galectin-1. So there are several molecular factors that determine how a drug interacts with the body. The first one is the binding affinity of the drug. The second is the eliminating half-life, the potency, and the clinical targets, and lastly the molar dose. So the binding affinity determines how strongly a drug interacts with its target, and data from head-to-head study, the binding affinity, as we see this figure is from ranibizumab is 2.18, Vorolizumab is 1.3, and aflibercept is 0.170. The lower the KD value, the higher is the binding affinity. So as we are seeing in this slide, aflibercept was found to have statically higher VGF binding affinity than vorolizumab and ranibizumab in a head-to-head study. So the potency determines the required concentration of a drug to produce a defined effect. And the data from head-to-head study potency shows that faricimab data is not available. Ranibizumab, it has 10.82. Vorolizumab is 5.74 and aflibercept is 2.42. So as we see, the lower is the IC value, the more is the increase in potency. So the aflibercept has the least potency as we are seeing, so it has the most increased potency that is there. As we see in the half-life provides an insight into drug concentration in the body over the period of time, and data from independent studies estimate human half-life. Human half-life days are from brolizumab is 4.3 to 5.1 days. Ranibizumab is 7.2. Faricimab is 7.5, and again as we see that the leading one is with aflibercept, which is 9.1 to 11 days. Then the binding target determines the downstream effect of a drug on the disease pathology. So the single target, the dual target, and the multiple target. So brolizumab it binds only with the VEGF-A. The ranibizumab binds with VEGF-A, and faricimab has a dual target effect of VEGF-A and angiotensin both. But aflibercept, as we see, it has multiple targets and it binds with VGF, PIGF, VGF-B, galectin. So the downstream effect of a drug is really increased with the bind as it binds with all the four of these uh, available. So because of all these effects, and the aflibercept significantly decreases intraocular VGF and PIGF levels from baseline to month 2 in patients with DME. So VGF-A and PIGF are upregulated in a exudative retinal disease such as diabetic retinopathy, diabetic macular edema, and in AMD. So in patients with diabetic macular edema, the VEGF levels are up to 61 times higher, and PGF levels are up to 91 times higher. So if we see why are PLGF is an important target molecule, although other anti-VGF blocks VGF molecules from activating VGF receptors, presence of elevated PLGF can activate VGF receptors. So in the graph, we are seeing the VGF concentration in AH and PIGF concentration in AH in diabetic macular edema cases. So could targeting additional pathways beyond the GFR pathways further improve the efficacy outcome. So yes, angiogenic factors play a crucial role in the development of edema and retinal vascular permeability, inflammation, neovascularization, and vessel stabilization. So as we are seeing, we see that these angiogenic factors are playing a very crucial role. They because of this angiogenic factors, edema, retinal vascular permeability, inflammation, and vessel stabilization take place. So as we see in the diagram, vascular leakage, inflammation, and pathological neovascularization and survival and inflammation. So is the angiotensin 2 type 2 pathway a relevant target in the treatment of exudative retinal detachment? So during the angiogenesis, ANG2 is upregulated and and it competitively binds with type 2. So in high VGF states, the ANG2 is an antagonist. It activity may promote destabilization of blood vessels. So whenever there is a high concentration of VEGF, uh, so there is a antagonistic effect which helps which leads to the promotion of destabilization of blood vessels. And in the low VGF state induced by an anti-VGF treatment, ANG2 may have limited relevance. So aflibercept is the most potent binder of VGF compared with other available agents, as we have seen in the previous slides. So Bayer and Regeneron have investigated the ANG2 pathway in combination with abelacimab in the Ruby and ONYX studies, and these are data from the independent studies to know the kinetic binding of, so which has seen that faricimab has the binding of 22,000 and the TYR2 receptors have 3,000 and nesvecumab has to have 24. So faricimab has a weaker binding affinity of ANG2 than for the TYR2 receptors, and nesvecumab has a stronger binding affinity for ANG2 than for the TYR2 receptors. So these are data from separate studies suggest that nesvecumab is a more potent inhibitor of ANG2 than faricimab. So in Ruby and ONX targeting both the ANG2 and VGFR pathways did not provide additional improvement in vision. So this is very important that there has been no additional benefit seen with the potent ANG2 inhibition in combination with aflibercept. So ABC aflibercept 2 milligram plus nesvecumab which is a potent ANG2 inhibitor. The phase 2 trial have seen that combination with nesvecumab provided no additional functional benefits versus aflibercept monotherapy. So with this study, there it is seen that the monotherapy is as equally effective than the combination therapy. And these are the various doses with aflibercept with nesvecumab. So and with aflibercept monotherapy. So the monotherapy is as effective as the combination with the nesvecumab. So unbalanced study design favoring faricimab and additional ANG2 targeting with faricimab did not confer any additional clinical benefit over aflibercept alone. So vision gains with faricimab were non-inferior to those with aflibercept at the primary endpoint. In the Avenue clinical study, ranibizumab and faricimab achieved similar levels of plasma ANG2 inhibition after one injection. So both they have similar level of plasma ANG2 inhibition. So these data suggest that anti-VEGF monotherapy neutralizes ANG2 to level comparable to the achieved with directly targeting ANG2, thus aligning with the known biological activity of ANG2, whereas ANG2 is downregulated by decreasing VEGF levels. So this data is suggesting that anti-VEGF monotherapy neutralized ANG2 to the level compared with the directly targeting ANG2. Thus, faricimab failed to meet the primary endpoint of superiority to ranibizumab for BSV again at week 36, and the level of ANG2 inhibition were similar between agents, suggesting that anti-ANG2 anti-VEGF therapy. So in this study, we have seen that the faricimab has had no additional benefits over the other anti-VEGF monotherapies. So with the aflibercept showed the most durable and robust suppression of VEGF in ANG2 versus brolizumab and ranibizumab. So anti-VEGF prevents VEGF-driven ANG2 production. This effect is greater and persists longer with aflibercept versus brolizumab and ranibizumab. The results of the study support the hypothesis that ANG2 may be suppressed secondary to primary insults to retinal vasculature by VEGF. So why is the ANG2 basically it may be expressed secondary to the primary insult to retinal vasculature by VEGF. And the other thing is that direct inhibition of ANG2 may not be clinically relevant as this is currently provided by anti-VEGF treatment alone. So the anti-VEGF treatment that is alone given currently, it does not help in any direct inhibition of ANG2. May not be clinically relevant. So with all the slides that we have, the thing has been proven towards comprehensive and highly durable targeting where it matters. So as we have seen this slide, that with all the drugs that are compared with faricimab, ranibizumab, brolizumab, and aflibercept, the clear-cut aflibercept is having a clear-cut advantage over the other drugs. So this is the additional pathway of that we are seeing. So the additional pathway of ranibizumab with the anti-ANG2 arm. So what are the guidelines recommended for anti-VEGF as first line to treat the CIDME is the diabetic macular edema treatment guidelines in India and this was an all India AIOS diabetic retinopathy task force and Vitreoretinal Society of India consensus statement. And it was concluded that intravitreal injections of anti-VEGF agents are the first line of treatment for naive CIDME. And laser treatment have shown to be an effective treatment option in the management of diabetic macular edema in the early pioneering studies compared to sham treatment, but is currently in the era of anti-VEGF clearly not the standard of care anymore. So the anti-VEGF is now standing as the first line of treatment, and the corticosteroids are important in our armamentarium of drugs for treating DME patient, but largely on a secondary choice level. So again, it's clear that anti-VEGF are the first line of treatment in the diabetic macular edema cases. So the RCT-like outcomes are possible with aflibercept in clinical practice. So these are the various studies that were conducted. So vision gains maintained through year 4 with a proactive dosing regime. Vision gains maintained through year 2 with a proactive TNE dosing regime. And vision gains achieved with a mean reduction in treatment burden after early intensive dosing. So, macular edema cases. So with the clinical case that we see, so aflibercept provides unsurpassed vision gains with an excellent safety profile across multiple indications as demonstrated by a wealth of RCT in real world data. So this was a more than 25,000 patients treated in clinical trials and real world studies, and it was more than so with over 13 million patients patient years of exposure. So now licensed to totally 6 indications since launch. So it includes the DME, NA, AMD, CRVO, BRVO, CNV, and NV. And it was more than 1 decade of clinical marketing experience. So in clinical practice of aflibercept, so the rate of endophthalmitis in a routine clinical practice of aflibercept is 0.1000 doses. So with all this, what does this mean for the patient? It means the wealth of data to support confidence in safety and efficacy of aflibercept across multiple indications. And aflibercept is the benchmark of efficacy and safety with the real world patient experience. So, in summary, as we conclude, aflibercept targets where it matters. It targets the VEGF and the PIGF, thereby inhibiting downstream signals via GF1-2, which is the master regulator of pathological angiogenesis. To date, both preclinical and clinical data suggest that there is no additional benefit of additional alternatives to VEGF binding affinity for VEGF, a greater potency for after longer VEGF agents, and these factors contribute to the strong VEGF suppression seen with aflibercept. So, in conclusion, I would state that with aflibercept 2 mg already targeting key ligands of the master regulator VEGF pathway, there may be limited potential for improvement in functional outcomes for patients. So, I think with aflibercept, we are much more safer and we have a very potent drug with us. So, I conclude with it. Thank you.
So thank you very much, Dr. Abhishek. So I'll request the panelists to please drive the discussion ahead and take the questions from the audience, or if you have any questions yourself directly for Dr. Abhishek, maybe we can start the discussion. Dr. Shilpi, Dr. Pranav.
Good evening, good evening, everybody. So, Dr. Abhishek, sir, there's a question that what is the efficacy of aflibercept in venous occlusions?
Hello. Hello.
Yes, Dr. Abhishek.
Yes, sir. Am I audible?
Yes, sir, we can hear you.
Sir, can you please repeat the question?
So Dr. Shilpi has asked that what is your take on the efficacy of aflibercept in venous occlusions?
With the venous occlusions that we have seen, I think like the most of the aflibercept we have used has generally been with the diabetic macular edema cases. But I think with the studies available, aflibercept does have a better role in venous occlusion as well. So, but our mainly experience have been with diabetic macular edema cases only.
Okay, sir, this could be a good option in venous occlusion since it is a longer acting molecule than ranibizumab. So we could try this in our center.
Definitely, yeah, because with a longer action, this is much more. This can be of.
Thank you, sir.
Thank you.
So do we have any other question for Dr. Abhishek?
Yeah, we will share.
So thank you very much, Dr. Abhishek. I think most of the things are very clear. So I'll request now our second speaker for the day, Dr. Suraj Bajwa, to please share the slides, and over to you, sir. Dr. Suraj.
Hello, I've just sent the request to share my slides. Can you please accept that?
Tech team, can you help Dr. Suraj to share his slides?
Actually, I'm getting a notification that host isn't allowing me to present my slides. So can you please help with that?
Okay. Tech team.
Already access given, sir.
Yeah, okay. So can you see the slides?
Yes, sir, we can see it.
So first of all, good evening, everyone. First of all, I would like to thank Spare for giving me this platform to talk about neovascular AMD. So I'll be talking about neovascular AMD, what the clinician should know. I'll be basically just touching about briefly about the symptoms, the diagnosis, and the management. Mainly, I'll be focusing on the role of aflibercept and the various clinical trials and the real-world evidences, and how the real-world evidences mirror the clinical trials. So starting my talk, these are the disclaimers. First, talking about the global prevalence of AMD. It is currently estimated that about 196 million people in the world are affected by AMD or any subvariant or type of AMD. And it is thought that this number would rise to 288 million by the year 2040. So we can say by the year 2040, 1 in every 30 people may be suffering from AMD or any variant of AMD. So there can be a substantial global burden of AMD on the healthcare system as well as on the patient. So talking about the symptoms, blurring of central vision is the most common or the earliest symptom that the patient will present to you. Along with this, they also say there's decrease in the contrast sensitivity. The second most common symptom is the distortion of the straight lines. The straight lines appear to be bended. Some may even complain of shortening or enlarging of images, macropsia or micropsia, which are usually rare. Then, as the disease progresses to the advanced stages, the patients present with a central scotoma. They say we see a black spot or a black hole in the central field of vision. So overall, there is a generalized haziness of the vision and decreased contrast sensitivity. What we need to remember is that the symptoms of AMD, they usually appear suddenly and worsen rapidly. Hence, it necessitates aggressive approach in diagnosing as well as management of this disease. So you can see in this picture how these symptoms can have a negative impact on the quality of life of the patients. In the first image, you can see there is slight blurring of central vision. Also, there is decrease in the contrast sensitivity. As the disease progresses to a later stage, patient develops central scotomas. Now just imagine a patient living with such a vision, how negative impact this can have on this patient's day-to-day activities. So talking briefly about the stages of AMD. First, the early stage. This stage is usually asymptomatic. There is slight building up of pigments or lipofusion along the RP brux membrane level. At this stage is usually a clinical finding or an incidental finding. The patient may come to you with some other complaint or something related to a retinal checkup, which he or she is recommended by the general physician treating him for diabetes or hypertension. So you diagnose this incidentally. As this disease processes to an intermediate stage, the drusen's enlarge. So this is the stage where the patient starts developing the symptoms. Main symptoms are the blurriness of the central vision and distortion of lines. So final stage, which is the vision threatening stage, is the late AMD. It again has two subvariants, the atrophic and the neovascular one. Atrophic is more common. They occur generalized atrophy of the photoreceptors, RP cells, and the brux membrane. The less common but the more aggressive one is the neovascular AMD. It often leads to a rapid loss of central vision, hence necessitates aggressive approach in managing this disease. Now talking about diagnosis of this disease. It is a multifactorial diagnosis. So we start with basics like the visual acuity and the Amsler grid. It tells us about the functional impact of the disease on the patient's sight. Then we move on to more clinical investigations like the clinical retinal examination for the structural assessment of the disease. By the real precision, it comes from the imagings like the OCT and OCT angiography, which tells us about the fluid accumulation and the structural changes in the retinal layers, and angiography for the vascular changes. Especially in cases like PCV, ICGA becomes a critical for accurate diagnosis of the disease. So the key message here is accurate diagnosis requires combining functional testing with advanced imaging to guide the right treatment for the patient. So as I have already told you that this is an aggressive disease. As soon as the visual symptoms appear, this disease progresses very fastly. So we have to keep in mind that the time lost is vision loss. Also, it has a dual goal that we not only have to treat the patient's disease and help patient gain visual gains, but also we have to reduce the treatment burden on the patient. So the cardinal points are early diagnosis, timely treatment, and enhanced communication between the patient and the healthcare professional. I would like to emphasize on enhanced communication. We need to clearly tell the patient about the nature of the disease, its progression, and what economic burden this disease may have on the patient. So if left untreated, permanent loss of vision can occur rapidly after the onset of the symptoms. So as Dr. Abhishek has already talked about the pathogenesis of the disease, I'll just very briefly talk about it. We all know at the core of this disease is VEGF activity. So this disease is basically a VEGF-driven disease activity. We have VEGF-A and PIGF, which both bind to the VEGF receptors, and these lead to these drive leakage, edema, and new abnormal vessel growth. VEGF-A mainly acts to the VEGF-1 receptors and 2, while the PGIF, it amplifies the pathway further. Together, they worsen the inflammation and neovascularization. So overactivation of this pathway is what drives the disease progression and vision loss. So various agents available for the treatment of disease are aflibercept, brolucizumab, ranibizumab, and faricimab. They all have different target molecules, some being multi-targeted, some are single and dual. Aflibercept here is the multi-targeted molecule which targets different receptors. So if we use brolucizumab or ranibizumab, they block the VEGF-A and their isomers. But we still need to remember that VEGF-B and PIGF are still in picture. They would still be able to bind to the receptors and therefore contribute to a downstream pathological effect. So here is where aflibercept comes in play. It binds to VEGF and PIGF as well, and hence stops the progression of the disease as compared to the other alternatives. So now talking about aflibercept as a choice of anti-VEGF in wet AMD, I'll be talking about the randomized controlled trials and the real-world evidences and how the real-world evidences mirror the randomized controlled trial. Talking about the landmark study in this, which is the ALTAIR study, we all know. So this slide shows the real-world evidence from the ALTAIR study in the treatment of the naive AMD patients. We can see that there was a meaningful visual gain, which was about plus 6 to plus 7 letters, which is very clinically significant. Importantly, this was achieved with around 10 injections over 2 years. That means the drug showed a good durability. And nearly around 40 to 45% of the patients were maintained on an extended 16-week interval by the end of 2 years. So overall, we are seeing a strong balance between the vision improvement as well as fewer treatment injections or increase in the duration of the injection over 2 years. So in simple terms, it works well and lasts longer for a significant proportion of the patient. Now this slide reinforces the durability we have been discussing about the ALTAIR study. Importantly, these gains were maintained through week 96. That is what matters, over 2 years. So total injections over 2 years were around 10 injections, which is a relatively low number. Also discussing about both the strategies, the 2-week and the 4-week one, both showed comparable outcome. So again, the key message is same, that sustained vision gains were seen with a reduced treatment burden over the time. And coming on to this slide, this shows that when patients who were given the 2-week dosing interval, they maintained in those 96.2% of the patients, they were able to extend to a 16-week interval. Whereas in the regime where 4-week interval was given, this was slightly lower, but it was still around 78%. But what is more important is when we look at the patients who not only extended, the patients like the week interval was not only extended to 16 weeks, but it was also maintained after that as well. Around 40 to 42% of the patient across both the groups maintained a 16-week interval after that as well. So a large number of patients can be seen extended, and around 4 out of 10 can actually maintain these longer intervals over a long period of time. In this slide, we see as well that there were early gains, and what is more important, that these gains were still maintained after the interval of 2 years, thus emphasizing on what I said earlier. The duration of doses were increased and visual gains were maintained simultaneously. Now, first was a randomized controlled trial. Now, this data what I'm about to talk about. The main important thing about this is that this was not a controlled trial. Data was taken from an FRB registry. In this, we can see as well that the patient achieved a meaningful vision, which was about +6 letters for over a period of 2 years. In the graph, you can clearly see the pattern. There was a quick improvement in the early phase. Then the vision was stable over the time. On an average, the patient received about 13 to 14 injections over 2 years. And importantly, by 2 years, about 1 in 4 patients were already on a 12-week or a longer interval. So even in the real world practice, we are seeing sustained vision gain with a gradual reduction in the treatment burden. To support the evidence, this is a study taken from the Moorfield. So this is a long-term study that extended to over 4 years. In this, again, the patient achieved a strong vision gain, which was similar to +7 to +8 letters. The key point was that these gains were maintained over 4 years with only a slight drop, but still it was above the baseline. So this shows that with the proactive treatment, we can not just gain vision, but sustain it in long terms in the real world practice as well. Supporting that, Jaggi et al. Also conducted a study. It was similar to earlier. Vision gains are achieved early and were maintained over the 4 years. What's different here is that this was done without even giving a full initial loading dose. So by year 4, the patient still maintained about +6 letter from the baseline. And importantly, we need to see is that around 35% of the patients were able to stop the treatment after about 2.5 to 2.6 years. So this suggests that not just the durability, but in some patients, even there is a potential to exit the treatment over time. So overall, we see there is a consistency between the real world outcomes, which closely mirror the random controls trial. Across studies, the patients achieved meaningful vision gains with a manageable treatment burden. So the takeaway is simple. These results are not just theoretical. They translate into everyday clinical practices as well. So after talking about the NAMD, we'll also see what role aflibercept plays in the management of PCV. We'll be talking with the help of the real world studies as well as randomized controlled trials. First, one thing we need to know, while the PCV is considered less common globally, it is actually more prevalent than what we thought previously. Especially in the Asian population, where it can be as high as 20 to 60% of the presumed NAMD cases. So the key shift here is that PCV is not rare, it's rather or often missed. So a study was conducted, which is called the PLANET study. It was conducted to know whether aflibercept alone is enough or in conjugation with the PDT. So to address this, the PLANET study looked at aflibercept alone versus aflibercept plus the PDT. In this, the patient received 3 loading doses, then they were randomized. Importantly, the PDT was only used as a rescue, not an upfront combination for the disease. And what results we got after 52 weeks? Let's see that. So after 52 weeks, that is 1 year, both the groups achieved over the 10-letter vision gain, which is quite significant. And importantly, there was no meaningful difference between the monotherapy and the combination. Also, the treatment burden was identical, about 8 injections in year 1. So early on, aflibercept alone performs just as well as adding the PDT. By the end of 96 weeks, that is by 2 years, the gains were maintained around 10 plus 10 letters. And the treatment burden still dropped significantly, that is 4 to 5 injections in the second year. So the durability is strong and we maintain outcomes with fewer injections over time. That was the takeaway message from this study. Now talking about the disease control, about the polyps. When we look at the disease control, over 80% of the patients had no active polyps at 1 and 2 years of interval. Though the complete regression rates are moderate, but functional control is still high. So clinically, what matters is that the disease is controlled in the majority of the patients. So comparing the real world studies and the RCT consistency across both trials and the real world studies, we consistently see a meaningful vision gain. And this holds true across different dosing strategies as well. So again, these outcomes are not just trial-based, they translate into real practices as well. Not just there were vision gain, but we were able to modify the disease or to control the disease progression as well. The polyp progression rates vary across studies, but consistently they were meaningful. So the signal is clear. The aflibercept works even in monotherapy as well in control of PCV. Now comparing the side effects to the other molecules that are available. So with brolucizumab, there is a known safety signal for retinal vasculitis and vascular occlusion, and the rates are relatively higher. With faricimab, the rates are low, but still reported and included in safety tables. With aflibercept, the key point is that the rates are extremely low, almost negligible in the real-world data. So overall, aflibercept shows a very strong and a reassuring safety profile. So after going through the studies and the real-world evidences, I would like to conclude with that aflibercept has a well-established efficacy and a safety profile. It is backed by data over a decade. There are millions of doses and global real-world experiences as well. There are low adverse rate events, and also it has broader use across multiple indications. So putting it all together, aflibercept delivers consistent or durable vision outcomes with a strong safety profile in the trial as well as in the real-world practice. Thank you.
Thank you very much, Dr. Suraj. You covered it very well, starting from the basics of the NAMD, the different treatment options, and then finally the role of aflibercept in the management of NAMD. Now, I would again request the panel or the audience if they have any questions for Dr. Suraj. Yes, sir, how has been your experience in this using aflibercept in NAMD? You talked about the treat and extend. So my question to you is whether you have followed this treat and extend regimen in any of your patients, and how has the response been?
So I'll be very honest that I've moved on to aflibercept lately, very
Yes.
recently, and just because earlier the drugs I used to see, I did not see a very drastic effect with them. And after using this drug, I've seen a much better response. But in the real world scenario, sometimes looking at the demography of the people, so
Yes, sir.
I usually follow PRN model in some patients because yes, as I was saying, the economic burden of disease is a lot on the patients as well. Where I have followed the treat and extend, I'm seeing a very good result, and also there is increase in the duration of dosing after the first 3 loading doses.
Okay, thank you, sir. So yes, we have also talked to a lot of doctors across the India, and economic barrier was a concern where they used to use PRN. So, sir, my another question is now since the price of the molecule has been made in a flat pricing of I think somewhere 29 or 30,000. So, what do you think whether it is going to impact the treatment regimen used by the doctors or the uptake of the drug?
First of all, I would like to thank Bayer for lowering the prices.
Yes.
And yes, in fact, this will be a benefit to the doctors as well as the patient. So, because in practice, we see when we give the loading doses, we get a better result as compared to just following the PRN model. So, it is going to be a beneficial aspect for the patients in the long-term treatment of the disease. As we know, usually this disease has a longer course. So this is going to be in favor of the patient as well as the doctors, and we can say to the patient that you need 1, 2, or 3 injections. Because earlier the first question the patient asked is, do we need a second one or the third one? That is because not the patient apprehensive about the injection, it is because of the economic burden. So that works in favor of the management of the disease.
Okay, thank you very much, sir. So, any other question from anyone else? So, I think, sir, there are no more questions from the audience also.
Thank you.
And again, I would like to thank both the speakers, Dr. Abhishek and Dr. Suraj, for presenting and covering the topics beautifully. And thanking all the panelists also, and rest of the audience for joining in and giving out their valuable time. So with that, if there are no more questions or queries for the discussion, then maybe we can call it a day. And thanks again, everyone. Have a
Thank you.
good night.
Thank you, sir. Thank you.
Thank you.
Thank you. Thank you. Thank you.
Can we close the session, sir?
Yes, we can close the session.
Okay, sir. Thank you.
Yeah.